All right, so as Dr. Leaf said, I'm going to talk to you about ERAS today and some things around the cystectomy. There was a bunch of literature around the subject, so I couldn't cover everything, but I chose some aspects that I found more interesting. So the plan for today is to discuss about key aspects of wound healing after radical cystectomy, to review some components of the ERAS protocol 10 years after its implementation, to explore the role of immunonutrition in the perioperative setting, and to reassess the need for post-op stents in radical cystectomy. So as everyone knows, radical cystectomy is a really morbid surgery, so reported with 50 to 80% complication rates and a 2% 90-day mortality rate, which in some studies goes up to 5%. There's a large body of literature that was published in the last 10 years, and still the adhesion to ERAS protocol is still variable among institutions. So our first subject for today is reducing wound complications. It's one of the most common problems with patients who undergo cystectomy. It causes increased morbidity and mortality. It's largely preventable, and it's a quite important economic burden on our healthcare system. It's divided in mainly two categories, so the SSIs, the surgical site infections, and the non-infectious ones. Today we're going to talk more about the dehiscence, incisional hernia, and peristomal hernia. And for radical cystectomy, the wound complications are the third cause of increased costs. So SSIs are defined as any infection, which is like superficial, deep, or organ space infection within 30 days of the surgery. And patients with SSIs are 60% more likely to require escalated care, 5 times the risk of rehospitalization, and two times the risk of 30-day mortality. The first aspect is smoking. So smoking is the most modifiable pre-op risk factor for wound complications. It induces peripheral blood vessel vasoconstriction, which leads to tissue hypoxia and hypovolemia. And being a non-smoker has proven to be to reduce significantly post-op complications. And they have shown that intensive intervention, such as weekly counseling and nicotine replacement, 4 to 8 weeks before surgery, leads to sustained smoking cessation rate of 20 to 30%, which is 2 times the usual rate. So in this table, what we can see is that in smokers versus non-smokers, just being a smoker is statistically significant risk factor for all of these complications except hernia. And if you stop smoking before surgery, they prove that it leads to lower wound healing complications compared to current smokers. So even if patients are smokers, when you see them before surgery, they still have benefits to gain from stopping to smoke. If we talk about adhesive drapes, the iodine adhesive drapes unfortunately didn't show any significant impact on SSIs, and standard adhesive drapes have themselves shown that there's a slightly elevated risk, so maybe not worth the shot. For disposable wound protectors, which in Quebec in French we call Alexis, they induce a 30% risk reduction in SSIs, and it's even better if you use a dual ring design. So these are usually used in cystectomy when you get to the recon part. So when you do the, let's say, the ileal conduit, where you kind of open up GI content. So these are to try to protect the wound. They're not costly. They're about $50 to $100 per unit. So they could lead to significant long-term savings if you save some risk of infection. For fascial closure, so we have many studies on this subject. So going back to 2009, Melbourne and al. Showed in RCT of over 700 patients that if you compare short stitch to long stitch, short stitch is usually 5 to 8 millimeters from the wound edge, and longer stitch is usually above 1 centimeter. They showed that short length significantly lowers the risk of SSIs and incisional hernia. The stitch trial, which is one of the more recent trials in 2015, showed they compared the same thing, so small versus long fascial bites during closure, and they showed that it has a significant reduced risk of incisional hernia after 1 year in the small stitch group. There's a new trial that came out in 2022 that compared the same thing, but they used monomax sutures, which is a resorbable suture, a longer time than the PDS that we usually use. And there was a trend towards short stitch, but it was not statistically significant at 1 year. For suture material, we have 3 landmark old meta-analysis that showed that using continuous monofilament and non-absorbable, such as proline, or slowly absorbable, such as PDS, sutures can minimize the risk of incisional hernia and fascial dehiscence. But what about more recent evidence? So 3 more recent trials tried to compare barbed versus non-barbed sutures. In 2024, they compared the triclosan-coated barbed suture, which is TCB, versus PDS for emergency laparotomy, and on comparing SSIs and fascial dehiscence. And in 206 patients, 70% of them were done in context of trauma, so we have to account for that. But there was a trend toward lower SSI risk with TCB sutures. And there was lower fascial dehiscence with the TCB as well, but this was significant. So 4% versus 14%. And when you sub-analyze trauma versus non-trauma, there was no difference in SSIs and fascial dehiscence. In 2025, a systematic review and meta-analysis compared again barbed versus non-barbed, but without the triclosan coated, which is, we'll talk about that later, but more than 12,000 patients, so it's a big one. And it showed that barbed sutures reduced SSIs significantly and even length of stay. It's 1 day, you'll say, but still 1 day in cystectomy is quite significant. But there were no difference in fascial complications such as evisceration and dehiscence. But the thing is, about 53% of the weight of the study was for one trial, which was done on recurrence after ventral hernia, so patients with really, really high risk of recurrence. So if we account for our patients, they're at lower risk than these patients, so it might be more effective. And the last one, the KEGOG 4001, was a multi-center RCT comparing, again, barbed sutures versus non-barbed for incisional hernias in gynae surgery. And they didn't find any statistically significant difference for incisional hernia at 1 year and 2 years, but the rate for barbed sutures was 0% compared to a low risk for non-barbed. So the question is it just underpowered and couldn't detect the effect? So why barbed sutures? They provide homogeneous distribution of the tension along the suture line. So the hypothesis is that they avoid segmental ischemia and tissue necrosis, which could lead to less infection and less fascial dehiscence. Also, there's no bulky knot, and that's the goal of the barbed sutures, to not have knots, so less nidus for infection. And why the triclosan coating? It's an antimicrobial compound. It's designed to prevent bacterial growth and reduce SSIs, and it has proven in prior trials that it does reduce infection rate. For closing the dead space. So excessive dead space during wound closure is a nidus for infection as well, and several techniques can minimize the risk. We have some obstetrics literature that supports closing subcutaneous tissue to minimize wound disruption. And this was proven to be a greatest effect in patients that have a subcutaneous fat thickness greater than 2 centimeters, which we kind of have often in our patients. And other studies similarly compared, suggested that if you don't close subcutaneous space in obese patients, then you might leave a drain to reduce the risk of infection. for closure practices, at the time of closure, a study showed that if you use an operating room bundle, you might reduce the rate of SSIs from 3.5% to 1.3% in all major uro cases. So cystectomy, nephrectomy, prostatectomy, and the OR bundle for them consisted of just allowing skin prep to dry appropriately before you start, which we don't always do. Changing glove before skin closure, which is quite easy to do. Irrigating the wound before skin closure, which is, again, easy to do and doesn't take much time. And using a new tray for instruments that is sterile and hasn't been used when you have bowel content in your incision. Negative pressure wound therapy. So I haven't seen anyone. Yeah.
Are I think rational and simple. Were they all incorporated into how do the randomized trials control for differing use of those procedures? Was it?
So it was the bundle itself that was.
No, but in the preceding trials where you compare suture versus.
Oh, I think
suture.
They just compared to the literature that they had, like the rate of infection, just a standard reported rate for cystectomy, without having concern for any of these.
No, I'm talking about all like the trauma surgeries where you did a randomized trial of this closure versus that closure, this suture versus this suture. Did they try to control for all these other variables that might have been used differently at different sites that might have accounted for
I'm not sure if they controlled all of these factors for the trauma surgeries that we talked about before. I think they just focused on barbed versus non-barbed. If we continue with negative pressure wound therapy, so I haven't seen any use of it here, like the PICO. So negative pressure wound therapy has the most benefit for high-risk wounds, which radical cystectomies are. There's a 10 to 30% risk of a post-op wound infection in our patients for cystectomy because they often have many comorbidities. They smoke, they have often diabetes, obesity, cardiac disease. Many of them have undergone neoadjuvant chemo, which impairs wound healing. And it's a clean contaminated surgery, which predisposes to wound infections. And in 2016, the WHO guidelines recommended the use of negative pressure wound therapy on primarily closed surgical incisions for adults with high risk wounds to prevent the SSIs. And what is nice about these dressings is that it's like they're all ready, so you don't have to fuss with using like you would have difficulty doing like a Fournier. These just come. You open them, you put them on the incision, and that's it. And the small machine will just start to work immediately. And you can keep the dressing up to 7 days, which is great because it protects the wound from everything. And if at some point there's leakage from the stoma or whatever, you just take it off and then you're back to normal. For prevention of
Sorry, on the negative pressure, a few years back I looked into that specific literature for cystectomy. That was and not anything particular to cystectomy, but one randomized trial showed benefit, but that was for those urgent surgeries. So that's what I've been thinking to do. I admittedly sometimes forget, but if you have like a patient that you have to take back, for example, or any urgent, those are the one that was in randomized settings shown to have reductions. So that was my takeoff when I had looked at it. Did you see any particular benefit from elective cystectomy, or you're just saying that it was just a general?
I did see some benefit. They were for like more higher risk patients. So either you have like obesity and chemo, or you have like patients that were on prednisone and then with obesity. So you have to have some like higher risk factors. If you're just like a lean patient, didn't have chemo, elective surgery, then I don't think you would benefit from it. But for these other patients, I think chemo itself just is enough to justify the people.
Sorry, Jen, one last question for this. Is there a minimum number of days so that patients actually benefit from this, or Like, would they go home with this and then, because they'd be discharged before?
Yeah, they can go home with this. Really simple. They just take it off and then close the machine, and it's disposable. So quite easy to go home with. And it's like they're not as loud as the usual vac, so they still can sleep and are comfortable with it. I think all the studies were done on like up to at least 5 days with the vac, but yeah. Yeah.
I used to send them home before 7 days back in the day.
Yeah, we were still, but
Yeah.
if you got 5 or 6 days, you might not want to ask them to trouble.
Yeah. So if you're the lucky one who leaves before 5 days, then I think you get to leave with a PICO. That's the goal. For prevention of peristomal hernia, they tried to show that prophylactic mesh placement was beneficial. And previous data that we had showed reduction of peristomal hernia. But then we have these 3 new, like more recent studies that all show that there's no benefit to adding prophylactic mesh placement. And it kind of adds a significant operative time. So they reported as long as like 31 minutes, and they said it was not statistically significant, but clinically 30 minutes in a cystectomy is quite significant. So not convinced about the mesh placement. The second part of our presentation today is to talk about these ERAS components 10 years after. So this paper was published in 2025 and kind of updated what the new evidence shows. So as we know, the ERAS is adapted from colorectal procedures, and it was adapted for cystectomy about 10 years ago. Multiple series have shown benefits for reduced length of stay, faster recovery of bowel function, and potentially lower complication rate. But the ERAS is not intended to be an all or nothing approach. So that's why I think the adhesion to the ERAS is not 100% in the studies. So they show that it's a dose response. So even if you don't use all of the components and you use just some of them, you still get some benefit from it. So you have to approach care with flexibility and adjust to the pathway that the patient is following post-op.
Genevieve?
Yeah.
Just, in terms of ERAS, like I'm an outsider looking in, but it seems like fast operative time is probably the best thing for a cystectomy.
It is.
The shortest, the least time under anesthetic, the less chance of a complication.
Yeah.
And it's just like when you're doing studies here, where in the US, you'll see like Dr. Glebe will be like 150 minutes or 130 minutes. And then there'll be some American surgeon who's got like 8 hours. And I'm like, how can you compare like to like,
Yeah, you're right. It's difficult to compare.
But that's a speculation. Is there data to support that OR time makes a difference?
I didn't see any when I didn't look for it specifically, but I didn't nothing just came up about operative time. I don't think they want to get into that too much because robotics takes more time, and they're trying to prove that robotic surgery is better for cystectomy. So I'm not sure if they want to prove that, to show just yet. Yeah.
Genevieve,
Yep.
Can you hear me?
Yep.
Just comment on your last slide. I think, one of the main things about ERAS is that it actually gives you a fairly rigid pathway. It's evidence-based, and you're not supposed to pick and choose and do whatever you want. That, a big part of it is actually standardizing each step of the care. So there may be a good reason why you don't do one or the other, but it's not a menu to pick from. It's something that you really try and do from first step to last step in a standardized fashion in every patient.
Yeah, I think it depends on how you see it. Your point is good, but I think they say that just as a reminder that it's not because you're following ERAS that you have to be blinded to what's going on clinically. So you have to divert from the ERAS if you see that the patient is not following the usual course. I think it's more, to just not let people be blinded and just continue without adjusting.
Genevieve, one of the things about ERAS is it's like a bundle. And if you pull out one or two pieces, you actually don't know which of those actually helps because they've been lumped together as part of a pathway. So
I know that's what ERAS said, but yeah. So I that's what I found in literature. So I mean, I understand and I follow this as well, but I think we have to just not be too concerned if some of the items get lost during the patient healing, because they might develop complications and just like we have to divert. That's just the point I think that they wanted to make. So that's the ERAS table that we're going to work from and go over each of the items in one after the other. I will skip over some of the components that are more standard of care. So for pre-op counseling, just generally, we know that if you counsel the patient well, the patients will have more resilience and be more adjust more to the surgery and their new life with the stoma after. So you can do it with workshops, multimedia resources, or just if you have time in your own office, but we usually don't. So one of the aspects of pre-op counseling that has shown some significant changes is stoma counseling. So they did a feasibility study, which was kind of like a stoma boot camp, which gave 3-hour group sessions within 2 weeks of the surgery to patients. They had short presentations. They had an ostomy nurse demonstrating some basic urostomy care, such as pouching, sizing, emptying, and troubleshooting tips for common ostomy problems. And they showed significant improvement on quality of life and ostomy adjustment score, which was persistent at 12 weeks post-op. This other trial showed that stoma counseling, again, like the stoma care ability, is the most important variable predicting positive adjustment to life with a stoma and increased perception of quality of life after surgery. So this prospective RCT was to investigate the efficacy of pre-op stoma education on the stoma self-care skills, and the intervention was just basic stoma care, training for change of appliance, practicing with an artificial stoma, counseling on life with a stoma, and follow-up prior to surgery to assess those skills. And what they used is the validated urostomy education scale, which is this one. And basically, it's just all the basic stoma care components. So you just have to like measure, remove the stoma, the skin care around it. So very basic. But this really helped to assess how the patients evolved with the training. And what they showed is that at 35 days, 120 days, and 1 year after surgery, the patients had a higher scale of stoma care ability than the non-intervention group, and it persisted over time. So it's quite worth it. Yeah.
Okay. Just wanted to mention with the bladder cancer supportive care program that is available virtually for anyone who wants in the province, we do a group educative session for like cystectomy, let's say, and chemo, but there's also a wound ostomy care nurse who do an educative session. It's about 2 hours. So it's 2 hours and it's held once a month. And so it's virtual. So we don't have currently the part of like the hands-on, practice of emptying, but at least the patients get to hear more about it. And currently, as it is, we also provide information for neobladder and DNA pouch, like those who are, the patient will get information for all of those, and partners are always welcome. So we do have currently something somewhat, providing information and more education, because currently otherwise how the wound ostomy nurse works in all, like they work differently in the province because it's different health authority. But pretty much as it is, the statu quo is that they get a phone call about, sometime before just to get the information, and they meet the wound ostomy nurse the day of the surgery when they get marked. And the teaching is done after surgery. That's what is the standard here.
Do they get does everyone with who's booked for a cystectomy get sent to that? or do you have to manage like yourself?
For what? The supportive care?
Yeah, the supportive care.
Yeah, so for the supportive care, like here in our patients, like our booking, and I mean personally, I will send them to I will task in Acro so that we get them, and our booking clerk does. But for the other urologist who's not working here, which is cystectomy, the patient can be referred, like just getting their contacts to the supportive care program. The patient can also self-refer, but it's obviously helpful if the urologist can just contact and offer that, because it's quite easy for the patient to get more information, and that way, all of those questions about, can I go swim? Like, those are kind of things. How do I empty the bag? What the bag look like? Those can be done by the teaching session by a wound-ostomy nurse.
Yeah, and do you think like you will at some point include some like in-person training for the this ostomy teaching?
Yeah, that's a good question. Like, it was something we were thinking. I was initially thinking, but it's because we're covering the province and we have a lot of people. Actually, most of people are not from living in Vancouver, but there is perhaps ways of improving with, it's a Zoom, so we can perhaps try to see, but the patient is not having it in their hand. So we can see how it evolves. Right now, it is a virtual Zoom.
Thank you. The next item is just pre-op medical optimization. So just generally, if you manage the health issues and if you screen the patient and you see that he has like non-controlled diabetes, or his like he says that his blood pressure is always in the 150s or anything, like you have time before cystectomy to kind of sensitize the patient to like managing his health issues more effectively, and involve professionals if you need to. So it's when the pre-op is the time when you want to try to modify risk factors that are modifiable, like as we said, smoking, alcohol consumption, physical exercise. If you avoid malnutrition and if you do pre-op exercise, you will get some benefit. And pre-op exercise programs have shown some benefit for like the cardiopulmonary reserve and the physical reserve for patients. And it was even better in patients that were at risk of deconditioning during their hospitalization. So nutrition has a really important role in decreased morbidity and mortality and improving the post-op recovery. And 21 to 55% of our MIBC patients are at risk of malnutrition before the surgery. And malnutrition and sarcopenia induce a high risk of overall and cancer-specific mortality. And the definition usually of malnutrition requires two of the following. So either you have insufficient energy intake, you have loss of muscle mass, loss of subcutaneous fat, you have an unintentional weight loss, fluid accumulation, or diminished muscle function. But if you just stick to the WHO definition of malnutrition, you might miss some things because it's just BMI of less than 18.5 and hypoalbuminemia of less than 35. What tools do we have for malnutrition screening? We have validated questionnaires, we have clinical features. We're going to talk about the skeletal muscle index and the lab findings. So for albumin, we have two different studies that show that hypoalbuminemia, the first one with less than 40 grams per liters, is a significant predictor of post-op complications and 90-day mortality after radical cystectomy. And each gram of albumin that you gain reduces the odds ratio of 90-day complication. And 40 grams per liters, I've rarely seen that in our usual cystectomy patients. And hypoalbuminemia in the second study, they defined as less than 35 grams per liters. And when you had that, you had 1.5 the risk, 1.5 times the risk of cancer-specific mortality and 2 times the risk of overall mortality. So it's quite significant. For sarcopenia, also associated with complications, cancer-specific mortality, and overall mortality. And the skeletal muscle index for sarcopenia. So usually it's used more as a research tool. It has to be used with CT scan and like a software that calculates like different things. But if you just want to screen for sarcopenia, you can use it in a clinical context, just like looking at the appearance of key muscles at L3 on CT scan, like the psoas, paraspinal, abdominal muscles. You look at their appearance. So do they look atrophic? Are they like non-convex? Are they lower density? Are they fat infiltrated? All things that can like kind of give an idea that the patient might have sarcopenia. And we can miss the diagnosis in our obese patients or overweight because we think that they're well nourished just because of the weight. But 25% of obese patients are actually sarcopenic. The next step is immunonutrition. So what is it? It's nutritional supplementation of selected amino acids and proteins to try to upregulate the immune response of the body, modulate inflammatory response, and influence protein synthesis. And we have controversial data on its effect. So some trials show good outcomes on post-op complications, alias infectious complications, but others show really no benefit. So this study was presented at the 2024 ASCO meeting. It's a randomized double-blind phase 3 trial. They tried what they called specialized immune-enhancing formula, which was arginine, omega-3 nucleotides, and it was given 5 days pre-op and post-op, and it was randomized against just standard oral nutritional supplement, which was like Ensure. 200 patients, and the primary outcome was post-op complication at 30 days, and they showed no significant difference. And all the secondary outcomes as well showed no difference. But the thing is, quite surprisingly, that at 2 years, the overall survival showed a trend towards immunonutrition versus the standard one. So quite close. This systematic review kind of presents all the main studies that were done on the subject. And as we see on this table, some of them show significant reduction of surgical site infections, faster return of bowel function, less TPN, shorter length of stay, but some of them show no benefits. So kind of hard to decide here. But in conclusion with this, I think it's a simple intervention. It's inexpensive. It can be widely used in clinical practice. It has not really any downside to it, and it can potentially induce benefits on TPN requirements, return of bowel function, SSIs, infectious complication, and possibly even length of stay. Then avoiding bowel preparation. Yeah. Yep.
It's not that cheap though. I did look at those. They're kind of like Boost or Ensure. I forgot which brand that they make them. But if you're gonna ask the patient to buy it at home, I think it was like over $100, like a box or something. So some patient obviously can pay for it. Others might not be so interested. And the only randomized trial was negative, as you pointed out, not powered to look at OS. But it's somewhat of interest, obviously. I just wanted to, before you switch on your next topic, because the prehab part is quite important, and there's studies and trials showing benefit, and some still ongoing to show some benefit. For those who are not aware, again, the province where we're currently available and newly available is with the bladder cancer supported care program. We have now exercise and nutrition kind of services are available for free for patients. So we just started, and how the program is made is always like you have a group virtual session so that a bunch of information can be shared with more people, and then patients can get access to individual appointments. So for the exercise, they can have, the program is made that in total they're going to get like 6 appointments over the year. But we made it so that there's like a prehab. So if they're under chemo waiting for the cystectomy, they will have like individual appointments with shorter follow-ups, but like a first appointment individually to get set up a workout program and so on. So that's really good. And I highly recommend that, you get your patients to go there so that it, does show clearly benefit. And it's something that is available for the patients and have motivation to do those things. And again, same thing for nutrition so that they can have information, and also if they want to meet individually registered dietitian so that they can. Really, so that's just new, but I highly recommend you get the patients who have that for free.
Yeah, it does show some benefit, and even if for some patients maybe it won't, then at least they have the tools to kind of get better after surgery. So
Genevieve, can I jump in there again, because you're essentially giving a soft endorsement for something where the definitive clinical trial is negative. right? So I don't think we can endorse immunonutrition, which costs money and patients will feel like, oh, they need to run out and buy it, right? The SWOG trial was the definitive trial and there was no benefit.
Yeah. So it's just like, I think there was one trial that was negative.
There was only one trial, one good randomized trial that was negative. If it was a drug, it wouldn't be sold.
Yeah. Yeah. I think for me, what it says is that sometimes patients, like, I get asked pretty much every day, like, what can I do to like change in my diet to get better? Like
there's things that can be done.
Yeah.
Regulation is not the one with.
No.
But
So
if you're
yeah.
Sorry, yeah, as Dr. Black mentioned, the immunonutrition has not been shown in randomized settings to be beneficial. But if they ask you what they can do, is definitely like look at what they're eating. Most of them, if they're getting chemo, they're not having sufficient. I mean, I'm not saying they all, but they are at risk of not having sufficient protein intake, vitamins, and those kind of things. So there's things that they can do. And the issue is, the point is, immunonutrition is negative. So
Yeah, for now. Yeah, I think there are studies still like trying to.
Yeah. I mean, we might find out those studies, but as the current state of knowledge.
Yeah. I think I'm just saying I'm not against it. Like if patients want to. Yeah. Yeah. Because people here, I think, want to pay for things. So like if they want to pay for that, I'm not against. I won't say that it's magical and it works. Yeah. Yeah. We have to be honest here. People want to pay for things here. So the next item is avoiding bowel preparation. I didn't get into that because it's quite standard of care now to not do it. If we get into pre-op carbohydrate loading, so just to explain what it is. So one of the studies showed that the goal is to reduce insulin resistance, influence peri-op complications, and address patient anxiety, hunger, and thirst. What they added is the immunonutrition beverage, but also a complex carbohydrate beverage the night before surgery and 2 hours prior to surgery. And it showed that there was earlier return to bowel function, reduced length of stay and insulin resistance, and no difference in complications or readmission rates. The pre-op fasting, so kind of goes with what we were talking about. So overnight fasting acts as a stressor on the body. It exaggerates the body's efforts to return to homeostasis and augments the catabolic response to surgery. It has been associated with insulin resistance and impaired wound healing. So patients should be encouraged to eat a healthy, well-balanced meal the night before surgery. And then international standards for anesthesia now endorse the consumption of food up to 6 hours before surgery and clear liquids up to 2 hours before surgery. But many institutions just continue to implement like the NPO at midnight and don't bother trying to change these. For long-acting sedatives, so just in general, if you have the patient have counseling before surgery and the patient arrives with less anxiety, then they might need less benzodiazepines to reduce anxiety. And if the anesthesia has to give it to them, then we really prefer the short-acting ones and the long-acting ones because they really have a significant risk of psychomotor impairment and cognitive dysfunction in the post-op in patients over 60 years old, which is a good population of our cystectomy patients. For thromboprophylaxis, so 3 to 12% rate of venous thromboembolic events after cystectomy. So the recommendation is that all patients should be offered 4 weeks of post-op thromboprophylaxis unless there is bleeding. It is either heparin or PO factor XA inhibitor. It should start on post-op day 1, and it has a high level of evidence and strong consensus. The CUA guideline says the same thing, and they don't make a distinction between open, robotic, and depending on risk stratification. It's just everyone with cystectomy should have the pharmacological prophylaxis for 4 weeks. And what they say is the same thing, low molecular weight heparin, starting the morning after surgery and for 28 days. Yep.
Can you remind me of the absolute and relative benefits of that? What is the data?
I didn't
I
show
mean,
like all the. I don't have the specific numbers for it.
I think that's if you're going
For
to.
example,
I'm always curious about absolute relative differences.
I could
That's all.
try that
Yeah.
for you.
I think that's where time on the table doesn't matter.
Yeah, I mean, that's there and other covariables that have influence it. So strong consensus. It's
Yeah, I also I didn't present it, but I also saw that even just because of the neoadjuvant chemo, that they should all be on like Eliquis or like PO XA inhibitors just because they have chemo before, like the combination of chemo and cancer.
Changing now with ADCs and IO.
ADCs. Oh, I'm not. I don't think they have the data yet because we've changed with Durva. Yeah.
Just because CO guidelines, I mean, it's 2018.
Yeah.
It states like, you know, sub-Q, low weight. But so we've switched to oral,
Yeah,
apixaban,
which
as
is-
you know. It's not endorsed in the guidelines, but it's
They
pretty much,
just haven't
yeah.
updated yet.
And we've published the results here that we've been doing for over 2 years now, and there's like no bleeding, no risk, and no DVT or P. Like basically, it works totally
And
fine.
when did you started the PO?
In March 2023. Oh, sorry, when they're going home.
Okay.
So instead of having sub-Q
Yeah, you
at
have
home,
sub-Q during. Like,
they have
in the
sub-Q while they're in the
hospital
hospital, and then they go home with a yeah.
All right. Yep. So AUA update on ERAS says the same thing for 4 weeks after surgery. The next one is epidural anesthesia. So this for me was quite a shock coming here. So for us in Quebec, it's still like standard of care to do epidural for radical cystectomies. Not as much for robotic surgery, but for open surgery, it's kind of a given that you get an epidural if you can. But they have been associated with elevated odds of any grade complications compared to general anesthesia alone, for sure. And RCTs compared epidural and GA versus GA and other ways to do it, such as rectus sheath catheters, liposomal, bupivacaine injection, or posterior quadratus lumborum block. And they show comparable analgesia in open cystectomy. For robotic cystectomy, even showed that intrathecal block proved to be non-inferior to epidural, and they had all of them had fewer episodes of early hypotension after surgery. So the current evidence now doesn't recommend epidural as like the standard of care. Okay. Yes, so minimally invasive approach. So if you do robotic surgery, but you do the diversion extracorporeal, you have no benefit basically compared to open surgery. But if you do it all intracorporeal, then it shows a superior number of days alive out of the hospital. Overall complications are not like significantly different, but there is a reduction in DVT and wound complications. And at 5 weeks, patients had increased stamina, quality of life, and less disability. And sometimes robotic approach facilitates implementation of ERAS, such as like early immobilization. So in conclusion, the expert panel recommended like minimally invasive surgery in the ERAS pathway.
That sounds like an advert for robotic cystectomy.
Kinda.
That's just total bullshit.
and how many people are on the panel that are?
Yeah.
Yeah, I'm just talking about what the evidence and what the conclusion is. Are they congruent?
No.
And to say that definitely the conclusion is it supports robot surgery.
Can I point out on this one that there is an ERAS society and they have a cystectomy committee that's revamping the guidelines. And this is a bit of a rogue group, I would say. That this is the Robotic Society of Europe. So the robotic surgeons are coming out saying that surgery should be robotic. So I agree completely with Andrew's summary statement.
Did you say he agree with you?
Huh?
Yeah,
Did
I
you say he
think so.
agrees with you?
Like, I think robotic surgery has benefits, but like as we said, it depends also on operative time. So if you do cystectomy in 150 minutes, let's say, I think you wouldn't get as much benefit from robotics if it took you like 6 hours to do robotic surgery.
Surgical science and oxymoron.
Yeah.
They're gonna start evaluating data like this and making conclusions like this.
Yeah. The next item is drain. So robotic surgeons tend to not leave drains in cystectomy more and more. But we have like different evidence, like not much evidence, in fact. So it has to be interpreted with caution. It's weak evidence. And there is this single, like one study, it's retrospective, single institution, doesn't have a control group, but they said that it showed that it's safe to not leave a drain. But I think like with this kind of evidence, we can't like definitely say, oh, not leaving a drain is safe. You have to have a better evidence. So the panel agreed to not recommend to omit a drain. Antibiotics, we don't have like really good guidelines or recommendations. AUA recommends single dose antibiotics, but showed that 72% of people don't adhere to that, don't respect that 24 hours and give longer antibiotics. EAU has no specific recommendation. CUA has no recent guideline on the subject, so there's really low level of evidence and it's all heterogeneous. Opioid sparing approach. I think I will go rather quickly. It wasn't the goal of my presentation, but it's the cornerstone of ERAS to kind of have multimodal anesthesia. It was associated with faster bowel recovery and reduced lengths of stay and complications. So really important to do as much as we can to give anything else to patients. And then if you don't have, like if you give everything else and the patient is still in pain, then that's when you give opioids. Fluid management, I just wanted to touch base on that. So it's not something I'm familiar with. So they reported that common elements in anesthesia protocol in radical cystectomy was to do restriction of IV fluids when ureters are clamped. Some protocols even include levoperfusion and fluid restriction until bladder is out, and all the blood loss to be replaced with crystalloids. But it hasn't shown any clear benefit. The goal is for post-op ileus rate, for like anastomotic, GI anastomotic edema, and just ileus in general. But it hasn't shown any benefit on that, and it has shown increased rate of AKI. Urinary drainage is one of our, like the last big subjects is the stentless procedure. So historically, stents were introduced to favor urine flow, reduce obstruction by the post-op edema, reduce anastomotic leakage and AKI. But new theories are emerging about stents. So new data that show no significant difference if you leave a stent or not. Some data is in favor of less complications if you don't leave stents. And some evidence shows also that inflammation and higher risk of UTI with stents may contribute to more fibrosis, so anastomotic stricture. And it was shown that some of the like inflammation markers or kidney injury markers are secreted in bigger quantities with patients that have stents. So they might induce a local reaction, which could lead to anastomotic stricture in time. And possibly stentless procedure could potentially save time and money and reduce the risk of post-op infection when we remove them. So now the new evidence tries to challenge old, traditional beliefs, but we still have no idea of what is the exact optimal duration of stent after surgery. We have an idea of short versus long. We'll get into that after, but the evidence is not that precise. For type of stent, they studied double J stent versus Bander stent, which are the single Js, and it would possibly be better to use single Js for less complications such as blockage, slippage, and stricture. We don't have any data on should we leave a catheter in the ileal conduit or not, and early removal of catheter and start of CIC in neobladder, not enough evidence. So on stent duration, what we have is a study that showed that there was a lower stricture rate in early stent removal group, which was removed on post-op day 5, and it was lower than the late stent removal, which was 2 weeks or more after surgery. So we're gonna go through a few studies. I know we're out of time, so I'll go quickly. So this one tried to evaluate some parameters on day 1, 3, and 7 after surgery, such as creatinine drain, upper tract dilation, time to bowel recovery, serum creatinine urea, and incidence of metabolic acidosis. It showed more urine leaks on day 1 when you didn't have a stent, but no difference on day 3 and 7. The stents decreased upper tract dilation, improved recovery of bowel function, and decreased metabolic acidosis, but there was some confusion about the effect of did they all leave catheters in the ileal conduit or not. There was no patient with early stricture, but there were 3 patients with stents that required treatment for strictures at 12 months. Another study showed that there was higher rate of stricture with the stented group, but it wasn't statistically significant. But there was no difference in urine leaks, which is interesting. This study showed that despite their population wasn't comparable, so the stentless group was older, had more comorbidities, had more chemo before surgery, baseline TKD, but despite the higher comorbidity, the stentless cohort showed lower rates of anastomotic complications, and the stented group showed higher risk of urinary complications. So that's what they say here. So if you have ileal conduit or you have the entire cohort, having a stent led to more cumulative incidence of urinary complications. That's what they show here. So what is interesting in that table is that there's no difference in leaks, UTIs, abscesses, and sepsis if you don't leave a stent. And there was a difference in favor of stentless for anastomotic complications and urinary obstruction. So this one was actually published in 2025, and this one seems to be kind of against. So it was done on many, more than 5,000 patients, but 9.2% only had stentless, and among the stented patients, fewer of them had robotic surgery. And there was no difference in overall 30 days of all these complications, no overall difference in minor, major, and urology-specific complications. But then if you go in for individual complications, if you look at stented patients only, they had lower rates of urinary leak or fistula formation. If they had stents and open surgery, they had lower rate of infection. And stented patient with robotic surgery had fewer minor and major complications, less UTI, less GI leak, less readmission, and shorter length of stay. So this one is actually in favor of keeping a stent for robotic surgery. This one, so meta-analysis and systematic review, 2025 again, compared outcomes with or without stent. And in the stent group, there was higher complications. And for all the other outcomes, there was no difference, stent or no stent. The thing is, in that big study, among the 6,000 studies that were evaluated, only 3 studies were eligible. And despite their prospective and randomized design, they all demonstrated high risk of bias. The rest is more standard of care, like avoid hypothermia, removal of NG tube, pain control. That's all really a standard of care now. So in conclusion, you can do easy and feasible changes for wound closure to reduce risk of SSIs. Immunonutrition is inexpensive and possibly beneficial, but maybe not. Stoma counseling can significantly help perceived quality of life after the radical cystectomy. Epidural anesthesia is no longer a standard of care, and there is some interesting new data on a stentless procedure. So I want to hear your thoughts about stent versus stentless, but also thank you for your for listening to me, and happy birthday to Dr.